Our second speaker for this session is Dr. Ammad Akram Chaudhary. He's from Armed Forces Bone Marrow Transplant Center. He will be delivering a talk on hemopoietic stem cell transplant outcome in AML, insights from single center operating in LMIC.
So good afternoon, ladies and gents. I hope you're having a good day. My name is Dr. Ammad Akram Chaudhary, and I'm from Armed Forces Bone Marrow Transplant Center. I'm truly honored for this opportunity of presenting my abstract on hematopoietic stem cell transplant outcomes in acute myeloid leukemia, insights from a single center operating in lower middle income country. So there are no disclosures. Well, acute myeloid leukemia belongs to a heterogeneous group of malignancies which are difficult to treat, and particularly in LMICs where advanced diagnostics and targeted therapies are not available, the transplant remains the mainstay of the management, and it's probably the only potential cure we can offer to our patients. Adding further to the peculiarity of management of AML in LMIC is the paucity of regional data on the disease, non-standardized treatment practices, underdeveloped healthcare infrastructure, so on and so forth. So the aim of this study was to analyze the transplant outcomes in patients with acute myeloid leukemia and correlate them with various disease and transplant-related factors, and to suggest measures in order to improve the transplant outcomes. So this retrospective observational study was carried out from 2006 to September 2024, and it included 83 transplant cases of acute myeloid leukemia from AFBMTC. As you can see, the majority of our patients were male, and most of the patients were in the 11 to 40 years age bracket. The median age at transplant was 22 years. And from the available disease-related data, 17% cases were stratified in favorable, 69% in intermediate, and 14% in adverse risk category. As you can see, more than half of these patients were in CR2 at the time of transplant. The majority of the donors were siblings. So 74% transplants were match-related donor transplants. We did 17% haploidentical transplants, 9 were autologous stem cell transplants, and the median days from diagnosis to transplant were 270 days. Majority of the patients did not have any ABO mismatch, whereas 17% had bidirectional, 11% had major, and 8% had minor ABO mismatch. And from the available data, the majority of the patients received myeloablative conditioning. In GVHD prophylaxis, CSA or tacrolimus with methotrexate was the commonest GVHD prophylaxis, and 19% of the cases were given PTCy, and 40% of our patients were exposed to ATG. The commonest source of stem cells was bone marrow harvest in about 55% of the cases, followed by PBSC alone and BMH plus PBSC. 8% cases received PBSC for autotransplants. The median cell doses used are as flashed. So post-transplant complications included mucositis in 86% of the cases, febrile neutropenia in 52% of the cases, gut toxicity in 37%, and CMV reactivation in 30% of the cases. And from the available data on GVHD, 48% of the cases developed acute GVHD, and amongst which only 20% had grade 3 and 8% had grade 4 GVHD. 37% of the patients had chronic GVHD, from which only 18% had extensive chronic GVHD, and it was found to be significantly associated with the higher CD3 dose. The overall survival of the current study was 62% at 1 year, and the OS plateaued at 57.8% at the 2 and 3 year mark. Similarly, the disease-free survival was 54% at 1 year, and it plateaued at 44.3% at the 2-year and 3-year mark. The current study demonstrated that there was a superior post-transplant overall survival in the patients having a lower risk disease at outset. The current study also demonstrated that the overall survival was superior in patients who were in the no CMV reactivation arm. And when compared to the data from the neighboring LMIC, which was published by Sharma et al., which reported a 3-year overall survival of around 50%, our study shows a superior 3-year overall survival of 57.8%. And in comparison to the data from CIBMTR, which reports an OS of 61.7% at the 3-year landmark, our study demonstrates a comparable OS of 57.8% at 3 years. Also to note that the current study did not demonstrate a statistically significant relation between OS and these factors such as the age group of the patients, the remission status at transplant, ABO mismatch, the type of transplant, the source of the stem cells, or the GVHD. So to conclude, I would reiterate that acute myeloid leukemia belongs to a heterogeneous group of malignancies which are difficult to treat. There's obviously a paucity of the regional data. Also to note is that our results are comparable to the CIBMTR data. Need of the hour is the coherent treatment guidelines and multi-center studies at national level. Thank you very much. So transplant-related mortality was calculated, and it was around 5 to 10%. So TRM was calculated for up till day 100 post-transplant, sir.
Thank you very much, Dr. Ammad, a very impressive study. I just, for the audience, kindly explain what was the indication of transplant in favorable risk AML.
So the favorable risk category transplant candidates were those who had a relapsed refractory disease, and they were given salvage therapy, after which they were taken to the transplant. And they were obviously fulfilling the eligibility criteria for transplant as per our institutional guidelines.
Dr. Ammad, again, a very good presentation. My question is that as far as the transplant age and other comorbidities are concerned, can it be a possibility that we in our country are selecting, relatively fit and good and younger patients as compared to other countries in the context of our comparable results?
So it's a very good question. Actually, we need to see into a few factors that in our part of the country, the patient present earlier to the healthcare setups with rampant disease, and due to the underdeveloped healthcare infrastructure, they are taken to transplant at an early stage. Since we have a paucity of data which is dealing with the chemoconsolidation alone, so our preference is to take the patient to the transplant as soon as possible. But we do consider transplant in older, fitter patients who meet the eligibility criteria for the transplant. So yes, in a way, it appears that there's a selection of the patients who are fitter, but we do often show flexibility on that while selecting the patients. And there are older patients who are taken to the transplant. As you can see, there were a quite good number of patients who were above 40 who were taken to transplant in this cohort. So.
I would like to humbly add another point. So all the favorable risk who are not taken to transplant otherwise, in the intermediate risk, institutional policies, if the fully HLA matched donor is available, we take the patient to transplant. But the problem is whoever we label intermediate risk due to not having any cytogenetic or molecular abnormality might not be the intermediate risks in the longer run because we have the limitations of testing. So if HLA matched donor is available, it's better to take the patient to transplant after 2 courses of chemotherapy. Thank you.
So can I ask one question? So more than 50% in fact, 60 or 70% of your patient cohort, they've had bone marrow as a source or bone marrow with some PBSCs. And the GVHD, acute GVHD that you've quoted is around 50%, out of which you said 28% were 3 and 4. Was it 28% of the 50% or 28% of the whole group?
So
And
that was
secondly, did you break it down according to PBSC and bone marrow as the source?
so the percentages were from the cohort that developed GVHD. So there was GVHD data which was available for some of the patients on which the percentages of grade 3 and grade 4 GVHD was calculated. And yes, there was slightly more GVHD seen in the patients who had received PBSC or BMH plus PBSC, but that was not statistically significant, hence it was not shown in this presentation, sir.
And did you look at the disease-free survival again, those who had PBSC? Well, the patient number was small anyway in the PBSC group, so it's difficult to.
Sir, yes, we did analyze the stem cell source along with the DFS. It didn't have any statistical significance with the overall survival or the disease-free survival, sir. Obviously, the cohort is small, and I hope when the data matures and we have a larger number of cohort, these results will be more indicative of the real pattern of the disease, how it carries forward itself.
Okay, you have mentioned CD3 count and its impact on GVHD. While regarding PBSC or BMH, what was your cutoff for CD3 count?
So we have only recently started noting down the CD3 counts. So there is usually the median dose of CD3 which was given was around 6. So whenever it is above 6, we are on our toes and we are on the look for GVHD when the patient is following up, sir.
CD3 dose was more in PBSC group or BMH group? Have you seen that also?
Ma'am, it was more in PBSC group.
So
and
GVHD was more in PBSC group?
Yes, but there was no statistical significance
because number was very small.
Number was small, and we were also giving PBSC in the patients who had received BMH to complete the stem cell dose.
What percentage of patients had T cell depletion?
So T cell depletion, as I've said, 40% of the patients, they received ATG for T cell depletion, sir.
So including the bone marrow?
Including the bone marrow harvest.
Okay. And you didn't see any increased relapse in the T cell depleted group?
So we did not. In fact, the relapse, out of the cohort, 16 patients relapsed. And there was no significance between the patients who had received ATG or not. But as a whole, from the cohort, 16 patients relapsed.
40% of patients received ATG. Were those patients high risk for GVHD according to GVHD score?
Yes, ma'am, they were. And from the available data, you see we had the data available on ATG for about 73 patients. And that was the cohort which was at the risk of GVHD.
Peripheral versus bone marrow, it kind of goes in the mix.
Sir,
when numbers are small.
So the autologous transplants were not considered when I was calculating the GVHD, nor were they considered for risk stratification. So the risk stratification GVHD were excluding the autologous transplants. But they were definitely included in the overall survival calculation, sir.
Thank you.
Thank you, sir.